This is the Get Healthy 360 podcast, where we discuss topics related to your physical, mental, financial, and spiritual health. Your host is Dr. Chris Ferguson, board certified in anesthesiology and pain management. This podcast is for informational purposes only, and you should consult your primary healthcare provider before making any decisions related to your health. And here's your host, Dr. Chris Ferguson. Oh, one more thing before we start. If you like this episode, please consider rating us 5 stars. We would really appreciate it. Thanks very much.
Welcome to Get Healthy 360. Today we are lucky to have with us Dr. Raslan. He started at Oregon Health as a neurosurgical instructor. He's a board certified neurosurgeon. And today what we're talking about is one of his areas of expertise, which is epilepsy. So Dr. Raslan, thank you so much for joining us.
Thank you, Chris, and nice to see you again.
Thank you. So to start with, how do you explain to someone who's not who doesn't have a medical background what epilepsy is and how it affects the brain?
Epilepsy is essentially an abnormal electrical activity of the brain. Now, the brain operates normally with electrical activity, so there's a normal range of electrical activity. When groups of nerves or neurons, which are the essential cells of the brain, synchronize their activity, electrical firing rate, or sending electrical signal, all at once when there shouldn't be, and that electrical activity results in activation of other regions of the brain or the body. That's where epilepsy is. And that's why you see people either, seeing things that they shouldn't see, or hearing things, feeling things, or moving or losing consciousness altogether. That has to do with the extent to which this abnormal electrical activity is involving what regions of the brain. When you lose consciousness, or you have the so-called tonic-clonic, the convulsive seizures, this is where the electrical activity has spread into vast regions of the brain that, the normal consciousness centers can no longer function. So to simplify, it's an abnormal synchrony of electrical activity when they shouldn't have one.
And what are some of the causes of epilepsy?
Epilepsy, can be caused by a variety of things. The most common form of epilepsy is what's called cryptogenic. Like you don't know how it started. We have an explanation for it, but what triggers that is not known. But you could have epilepsy as a result of inflammation or infection, which could be induced externally by a viral infection or bacterial infection, or it could be induced internally, what we call autoimmune reaction or autoimmune encephalitis. Could be induced by trauma. It could be induced by tumors. It could be induced by bleeding into the brain. So a variety of things. And it could be induced by genetic causes that leads to what's called genetic epilepsy, which could be inherited.
And how is epilepsy diagnosed?
Epilepsy diagnosed by a clinical picture in a patient that exhibit the signs of epilepsy, could be, most epilepsy has what's called impaired awareness, which doesn't mean you completely lose consciousness. You could have your eyes open, but you're not aware of what was happening, resulting with episodic activities that, involves either motion or feeling or disconnection for what's going on. So there are certain symptoms of epilepsy, but also a definitive epilepsy diagnosis is related to identification of that electrical activity, reading the electrical activity of the brain through the scalp, read out what's called electroencephalogram, and identification of these electrical signal in the regions that cause epilepsy. That's when you get a definitive diagnosis of epilepsy.
So the less invasive role, or one of the less invasive ways to treat this is with medications. So do you just want to talk about some of the medications that can be used to treat epilepsy?
Yeah, so the first line of treatment for epilepsy is medical treatment, and having one seizure doesn't make you epileptic, but having two will make you epileptic. So people could have one seizure in their life that doesn't repeat itself, and we wouldn't call them having epilepsy, and that could be related to What's most common cause for this is what's called febrile seizure. Kids who have the fever above 38.5 Celsius could have a seizure, and these are called febrile seizures, and you could have it once and never have it again in your life. That doesn't make you epileptic. But if you have two episodes of epilepsy that are not triggered by something like fever, then you are epileptic and you need to be treated. And the reason you need to be treated because, one, seizures begets seizures. If you continue to have seizures, your brain are more likely to have ones. And it could happen while you're crossing the road or doing things. So there is definitely a quality of life implications and risks and safety issues of having seizures. So you want to stop them. And the first line is medical treatment. And generally speaking, there's many classes of medication that works on different receptors and different ion channels in the brain, different mechanisms. But the general premise of all anti-epileptic is that they reduce spontaneous neural activity in the regions that cause epilepsy. And again, there are many classes of those, and some of them are safer than the others, some of them are more effective than the others, and some of them are side effects. Drugs such as Digritol, Keppra, phenytoin, zonisamide. These are the examples of the medication. And 2/3 of epileptic patients will respond to medical treatment, and either one or two medications combined could lead to that, and you could change the medication. But if you start medical treatment and with one medication and it doesn't work, and then you add another one and it doesn't work, then the chance that a third added medication working is actually less than 5%. So there's a condition called intractable epilepsy, and that's when epilepsy is attempted to be treated by medications and medication treatment fail, and we define that, but lack of seizure control despite use of more than two medications in an adequate dose and adequate compliance for more than 6 months. So somebody starts seizure for more than a medical treatment for more than 6 months, and they've been doing two medications and then appropriately dosed and appropriately used, and they still have seizures, then that means that medical therapy is no longer effective. And you could try more, but this is when we start thinking of other things other than medication. The other things, and so not all of them are interventional. Like one of the effective therapies or effective methods, not for everyone, is what's called ketogenic diet. And the reason ketogenic diet works in some epilepsy patients is because it reduces inflammation, and inflammation is known to be one of the factors that can lead to seizures or worsen seizures.
So I'm familiar with the ketogenic diet. I've never prescribed it as a medical indication. I've discussed it as maybe it was a weight loss thing, but from an expert who's actually used it in a clinical sense, are there any risks to the ketogenic diet or anything people really need to look out for?
Yes, of course. So my neurology partners use ketogenic diets. Of course, there could be risks for ketogenic diet. If you have diabetes and then you induce ketosis, that's not a good thing. Also, ketogenic diet is usually a high protein, high fat diet, low carb. So kidney function problems, people with heart problems and high blood pressure and atherosclerosis may need to be aware of the use, and I don't recommend using ketogenic diet forever. Most epilepsy patients who use ketogenic diet, we choose the younger population, like young adults or teenagers or adolescents. They usually don't have these sort of issues about the kidney function or blood pressure or the cardiovascular issues. So you could afford to ask them to do a high fat, high protein diet. But in older age, most people don't do ketogenic diet for more than 6 months and stop it, and that's an effective method for weight reduction. But ketogenic diet reduces inflammation, and there are several medical uses for ketogenic diet, including in cancer. And then there are some theories that suggest that ketogenic diet may be even a radiation sensitizer. It improves the impact of anti-cancer therapy. So it has a multitude of health benefits, but when it's used with caution and it's used with the knowledge that which patients you shouldn't, or which group of the population in which we couldn't use a ketogenic diet at an aggressive regimen or for a long time.
So your area is neurosurgery. So what are your thoughts on the neurosurgical options for seizures?
Thank you. Well, great question, but let's be. There is many neurosurgical options, but in order to delve into that, I'd like to describe to the audience here how do we try to identify the mechanism of epilepsy, the theory behind epilepsy, and one important question we try to answer is what the question of focality. Is the epilepsy that we're treating a focal epilepsy, which means it starts in a rather localized region of the brain and then spreads to the rest of the brain, or sometimes what's called multifocal, and one area recruits another area, and a process called kindling, which is one of the reasons why you would want to treat seizures early on, because before one focus recruits another focus and makes it difficult. Or the epilepsy is what's called primary generalized epilepsy. And primary generalized epilepsy is an epilepsy at its start. It starts from a central core of the brain that activates a wide swath of brain region all at once, usually the thalamus. And why is that distinction important? Because if you are targeting focal epilepsy, and that focus is an area of the brain that is currently dysfunctional, or in a part of the brain that could safely be removed, then there is a chance of cure. And cure in epilepsy is a very valuable outcome, that if you're capable of achieving that, then you should try to do that. Why is that? Because people who are epileptic for their lifetime, epilepsy takes over their life. The social, economic, and personal implications of lifelong epilepsy could be vast. It's a life-threatening condition because of what's called SUDEP, sudden unexplained death in epilepsy. It might limit somebody's learning or earning potential for the rest of their life. They might not be able to be alone. They may never be able to drive. So epilepsy has a lot of implications. So imagine if somebody was young and 18 years old and gets diagnosed as one of those, then their entire life has been taken over. Being able to cure that and bring them back to living a normal or quasi-normal life is a significant, personal and societal impact. Therefore, we really want to know if somebody has focal epilepsy or multifocal epilepsy, or they don't have that and they have a primary generalized epilepsy. And from that, the treatment options that we have are split according to this. So for somebody with focal epilepsy, then the focal therapy which is the option to resect the part of the brain that is causing the seizures and to achieve cure, would be the treatment option. So resective surgery is the first line option if you have focal epilepsy. The classic example of this is what's called temporal lobe epilepsy, TLE. Temporal lobe is one of the most common form of focal epilepsy. The temporal lobe especially is more likely to be the source of seizure compared to the rest of the brain lobes for a variety of reasons, including having what's called archae or mesocortex. It's our primitive cortex that we inherit from our ancestor, biological systems. So these are not very well developed cortices, and these are more likely to have seizures. But temporal lobe epilepsy could be treated by a resection, or the newer technology that emulates resection, what's called ablation, laser ablation, meaning you burn the tissue in place without removing it. So that's one option, resection or ablation. If you cannot do that, and for whatever reason, because the epilepsy is multifocal, or because the epilepsy, the region of the brain that causes the seizure is a part that you cannot remove, then you resort to other things. Two classes. One is called disconnection surgery, meaning you're just trying to prevent the spread of seizures from one to the other. And that's very common for primary generalized epilepsy. It's called corpus callosotomy. or removal of a large part of the brain that disconnects right from left, which is done in kids, called hemispherotomy. And these are kind of big operations. But then there's the whole field of neuromodulation for epilepsy, in which our goal is no longer to remove or disconnect, but to change the brain electrical physiology. So either it's less likely to have seizure, or we detect the seizure at very early inception and, hit iron with iron or treat fire with fire, deliver an electrical stimulus very early on that abort this propagated abnormal electrical activity, or emulate ketogenic diets, meaning stimulate parts of the nervous system that are known to reduce inflammation and therefore reduce the likelihood of having seizures. And this brings the option for neuromodulation, which I'm sure you're going to ask me about, and these are called the vagus nerve stimulation, deep brain stimulation, and what's called responsive neurostimulation.
So, why would you choose one of the neuromodulation techniques over the primary surgery?
Well, I would choose a neuromodulation technique if the patient has multifocal epilepsy, meaning I cannot remove multiple regions of the brain, or if the patient has primary generalized epilepsy, meaning there's no option for resection or disconnection, or even if there is an option for disconnection, but you would want to try neuromodulation first because it's a reversible option. It's an option that, if it doesn't work, you could stop it or remove it, versus disconnection, it's an irreversible option. Or there are some instances, especially in temporal lobe epilepsy, and if you have the temporal lobe epilepsy in your dominant hemisphere and you have a very intact cognitive functions, and there is a small risk of cognitive decline after resective surgery, some patients choose neuromodulation because it does not disconnect or destroy their brain, and they are worried about the overlap of the epileptic zone with the normal brain. So we choose to go with the neuromodulation option at first. There's either the reasons that push us towards neuromodulation, either multifocal, primary generalized, to do it prior to disconnection because it's reversible, and or fear of cognitive or other neurological deficit.
So to start with, who does this surgery? Is this a general, like any neurosurgeon does this, or is this someone who's specialized in epilepsy?
Generally speaking, it's somebody who specializes in epilepsy, but the neuromodulation options, are variable. So the vagus nerve stimulation is an operation that is done not on the brain; it's done in the neck. The vagus nerve on the left side is identified in the neck, and it's exposed, and there's a wraparound wire. There's two of them with a ground lead in the middle that is placed around the vagus nerve with a battery, and that can be done by both functional neurosurgeon, of course, but also general neurosurgeon, and sometimes done by non-neurosurgeons, even ENT surgeons or head and neck surgeons or vascular surgeons, because the vagus nerve is between the carotid and jugular veins. So other specialists could do vagus nerve surgery. Most of them, I would say, the vast majority of those operations are done by neurosurgeons. Especially functional neurosurgeon, but they could be done by non-neurosurgeons or non-functional neurosurgeons. But the other forms of neuromodulation, deep brain stimulation, and responsive neurostimulation, they hinge a lot on the techniques and skills that are specific to functional neurosurgeons. So I'll be surprised if a non-functional neurosurgeon does these for epilepsy.
Can you discuss because I'm not really familiar with, I'm somewhat familiar with the vagus nerve stimulation, and I'm not familiar at all with the deep brain or responsive neuromodulation. So can you go through the indications or differences? So the indications, contraindications, risks, benefits, efficacy of these three different types of neuromodulation?
Sure.
In addition to, all three.
The indications are very similar for all of them, but there are specific difference to one or the other. So vagus nerve stimulation is the only form of neuromodulation that's indicated for children below 12 years old. So for pediatric population, you don't have the other options. You only have vagus nerve stimulation. and it's indicated for multifocal epilepsy or people who do not wish to have surgery or primary generalized epilepsy. We use it for that. The operation is done in the neck. The contraindication of surgery if you have a dysfunctional vagus nerve on the other side, or you've had reasons to not operate in the neck, such as neck radiation, or maybe tracheostomy that led to a lot of scar in the neck, or risk of carotid or vascular injury. These will be the reasons why to not do that surgery. The operation is a fairly straightforward operation. It's a day operation. People go home the same day. The device gets activated about 4 weeks after it's implanted for reasons that has to do with, you want the swelling and the surgical, changes that occur as a result of exposure to settle down before you activate the device. The device senses the impedance in the nerve, so if there's some swelling, you may end up not delivering the full dose of electrical stimulation until things settle down. The device is programmed by the neurologist, and generally speaking, you don't see the full impact of the treatment early on. You start seeing impact around 3 or 6 months, and then you continue to see progressive improvement of the result of surgery all the way up to 2 years. Does this therapy make people seizure-free? It's very, very rarely, maybe 1 in 10 will be seizure-free, but the success of these neuromodulation therapy is usually measured by what we call the 50-50 rule, which is a reduction of seizure frequency by 50% and seizure severity by 50%. I'll explain that a little bit. Seizure frequency is how many seizures you have a week, for example. And seizure severity could be measured in many, many ways, but let's just talk about time. So let's say if you have 10 seizures a month, each one of them lasts 10 minutes. When you have a vagus nerve stimulation, what we expect that you reduce your seizure frequency to 5, each one of them lasts 5 minutes. And that reduces the seizure burden. Over time, that could even get better with time. The complications and risks of surgery is the risk of any operation that you up in the neck. And in the neck surgeries are delicate. There are blood vessels, there's the windpipe, there is the esophagus, the food pipe. Injury to any of these is possible, albeit very, very, very rare. If you have a blood clot in the neck that could pinch the airway, it could be a life-threatening emergency for which you need to kind of open up the neck or even do what's called a tracheostomy on the spot to save people because they couldn't breathe air, their airway is pinched. But it's a fairly common operations. We do a lot of it. It's a very familiar option to the surgeon, and it's the oldest neuromodulation option for epilepsy. It's been around since the 80s and 90s, and it's available for kids and adults. The other two options are deep brain stimulation, which have pretty much as a very similar set of indications, similar to vagus nerve stimulation. It might be slightly more effective, and with the newer technology implanting in the brain in 2 different parts of the thalamus could target different types of epilepsy. But the goal of deep brain stimulation is not to approach the focus of the seizure or the regions where the seizures start. You target a central core of the brain that's connected to broad regions of the brain, the thalamus. And by modulating the activity of the thalamus and the connections of the thalamus, you reduce the likelihood of having a seizure by impacting the regions the thalamus are connected to. For example, the anterior nucleus of the thalamus is part of what's called the limbic circuit or the PAPES circuit, which is heavily connected to the hippocampus and the temporal lobe, an important driver of seizures in epilepsy. So it's common to implant electrodes in the anterior nucleus of the thalamus, especially in patients who have, for example, bilateral temporal lobe epilepsy. And temporal lobe epilepsy is resectable if it's in one side, but you cannot remove both temporal lobes because our ability to form memories is dependent on having one hippocampus, not 2. And if you remove both, then you're unable to form memory. And there has been a famous patient called patient HM, been a subject of many memoirs, novels, books, even a movie, that had bilateral temporal lobe epilepsy, and he couldn't hold a memory for more than 5 minutes, and he died in 2008. So that taught us that he couldn't remove both. So if somebody has bilateral temporal lobe epilepsy, which is actually common after autoimmune encephalitis, one of the causes that we mentioned before, then you couldn't treat them by resection, and DBS would be a good option for that. And there's another part of the thalamus called the centromedian nucleus, which is not connected heavily to the temporal lobe, but it's connected heavily to the motor regions of the brain, the motor circuits, frontal and parietal lobes. So if you have one of the, myoclonic epilepsy or primary generalized epilepsy or idiopathic generalized epilepsy, then the centromedian nucleus become a target. And this allows us this kind of granularity in choosing. So that's when you use deep brain stimulation. Some of these devices now has ability to sense brain activity and store them. And this could give you some idea about the impact of your treatment. So that's DBS. DBS requires a center that is equipped with the ability to implant devices in the brain with precision, such as robot or stereotactic device. This is always done in what's called level 4 epilepsy center. The National Association of Epilepsy Centers in the United States grades epilepsy centers into levels, and then the most sophisticated, most comprehensive one would be level 4, that has all sort of technologies and equipped with the human capital of the surgeons, neuropsychologists, PET scan, and inspect scan, and other things. So these are done usually in level 4 epilepsy center.
As a quick question, how many level 4 epilepsy centers are there?
I don't know the number, but I suspect there may be 75 to 100.
So quite a bit.
Quite a bit, yeah. And I think the level 3 and level 4 might be more than 200. So level 3 is just close to level 4, but lacks some of the, fancy elements. So some places with level 3 still do that, but it's recommended that if you're going to go do a sophisticated operation, do it at level 4, because they have the team. And remember, the surgeon does the operation, but it's at the behest and the service of the epileptologist. They talk together, they figure out what's the best therapy. Like, should we do vagus nerve stimulation or deep brain stimulation? Should we do anterior nucleus of the thalamus, or should we do centromedian nucleus? Should we do that, or should we just proceed to corpus callosotomy? These discussions in personalized treatment plans pair the patient needs and features are as a hallmark of multidisciplinary epilepsy center. So I would recommend doing that. Risks of deep brain stimulation is very similar to any deep brain stimulation in intracranial surgery, bleeding in the brain, infection, again, albeit very, very, very rare. But deep brain stimulation is continuously on in a cycling fashion. It is not implanted where the seizure focus is, and it does not care when you have seizure. It just changes your brain so you won't be having seizures in the future. RNS, responsive neurostimulation, is a form of DBS, intracranial, but two main differences. One, it has to be implanted either in the region that produces seizures, focal, or in a part of the brain in which, when you have seizure, you see the seizure activity marker in that part. In other words, it detects the change in electrical activity associated to seizure. It's only responsive, so it doesn't have a default or a background or baseline mode stimulation that's continuously on. It only reacts to the detection of seizure activity very early in its formation, and it triggers a small amount of electrical stimulation that's very brief, but it's enough to stop the seizure at its inception. And it records these events over an internal memory, and it could record on 4 channels all up to 6 minutes, and the patients could download them as they see fit, and then they several times in a day. So when you have this device implanted, after a few months, you get a log of the electrical activity of the brain continuously. And that's one of the benefits of having this device. So responsive neurostimulation is a closed loop, automatic, responsive, on-demand device for epilepsy it's really a wonderful piece of engineering, and it's one of the few neuromodulation technology that was developed in the US, started in the US, and only available in the US. So it's a very fancy form of deep brain stimulation, but it has to be implanted in the seizure focus region or in a region of the brain in which you could measure the seizure activity. And it's only responsive. It doesn't have an automatic mode.
Is there a difference in how well the responsive neuromodulation works versus the deep brain stimulation versus vagus nerve stimulation?
I think if you look at the outcome graphs of all three, they almost seem identical. But the reality is that we don't indicate them for the same group of patients. There is a similarity between vagus nerve stimulation and DBS and how we choose patients. But responsive neurostimulation, you implanted where I have identified where the seizure focus is, and you want to collect data and information. And there are some preliminary data to suggest that in certain focal regions and focal areas of epilepsy that you couldn't remove, responsive neurostimulation might be superior. So if I have a focal epilepsy that is bifocal, not multifocal, two, or focal epilepsy that I couldn't remove because of risk of neurological decline or cognitive decline, then responsive neurostimulation becomes the treatment of choice.
And then, so the efficacy would be about 50% and 50%.
Yeah.
Which I'm sure is life-changing for a lot of people.
And responsive neurostimulation could be life-changing. Could be.
Do you have any success stories you can share about people who've undergone these respective surgeries, or some of your favorite HIPAA-compliant cases?
Oh, yeah, I mean, I have actually right here on my wall, one of the patients has a responsive neurostimulation. His wife, made a little thing that has a device on it. Let me show you, bring it. See the camera here?
Mm-hmm.
Can you see it?
Raise it up to your face.
Yeah.
Oh, sure.
Yeah. And this green thing is the RNS.
Mm-hmm.
So this is a particular patient. This is somebody who was a lawyer, went to law school, was a lawyer, graduated as a lawyer, and had autoimmune encephalitis and started having seizures, very intractable, horrendous, very, very severe, aggressive seizures that took over his life. And then when we did the initial assessment, and sometimes we do have to do what's called diagnostic surgery, intracranial electrode, just to diagnose whether seizures are focal or not. And that's a whole world completely called robotic stereo EEG. When we did that, we knew that he had seizures coming independently from the right and the left temporal lobe. So he has bitemporal epilepsy. And we knew we couldn't actually treat this with resection. So we implanted him with RNS. And he got a lot better. He still had some seizures, but he got a lot better. But over the course of 2 or 3 years, when we analyzed all the activity coming from his responsive neurostimulation, we realized that he had about, let's say, 120 seizures. 99% of his seizures came from the left side of the brain, and 1 seizure only came from the right, and it was not clinically symptomatic. So we sat down with him, we told him, okay, we have this situation that, yes, you have bitemporal epilepsy, but it's very asymmetric. And on medications, it's one side that's causing most of the trouble. So we counseled him and we went from neuromodulation to resection and removed the left hippocampus, left the right side of the hippocampus electrode in place, and he's seizure-free. Not only is seizure-free, he's back to practicing. He passed the bar exam.
Oh, that's fantastic.
So that's an example of the power of epilepsy surgery. It could change people's life in ways that unlikely to see in other things. And then you could live a normal life. It's interesting. 6 years, battery died, started having seizures. So resection made him seizure-free, but also RNS battery completed that. And he needs both. He needs resection to get rid of his left temporal lobe, the device to maintain his right temporal lobe, which allowing him to maintain a memory and ability to function as a normal human.
But if you have a child with seizures, the only thing they could get is a vagus nerve stimulator.
Yeah, but the interesting thing that a lot of childhood epilepsy that's intractable is also focal and amenable for resection or laser ablation. So
That's interesting. What is something that you wish people knew about neuromodulation for epilepsy? Like, what's something, if you could just let everyone know, that is often missed?
So the first thing that I would like, that epilepsy surgeries, neuromodulation and otherwise, are not experimental. They're actually very, very clinically proven, because we are in the most advanced country in the world, and you assume that the knowledge dissemination and science, but the knowledge and the access to the knowledge, even among a medical professional, that epilepsy surgery is an effective, very effective surgery, and it's not experimental, and it's approved and successful, is an important piece of information. In fact, all forms of epilepsy surgery, resection, laser ablation, and all forms of neuromodulation enjoy level 1 evidence. Each one of those has multiple randomized controlled trials to show that they're effective.
So if someone has seizures that are mostly controlled, or what if they're actually, say they're well controlled, but they just don't want to be on the epilepsy medication because the epilepsy medication, those medications often give side effects. Would they be a candidate for this procedure, or one of these procedures?
They could be. The side effects of medications have to be worse than the disease to say that. So intractability is not only that they continue to have seizures, they have terrible side effects. So having terrible side effects will qualify as an intractable, and you become a surgical candidate. But if you have controlled seizures on medications, very well controlled, then surgery so you could stop medication is not proven that way. It could work, but you're taking a bigger risk doing it for that reason. If somebody has epilepsy and they're sometimes controlled, sometimes not controlled, and they don't know if they could be a candidate for epilepsy surgery, my recommendation to them is to seek an epileptologist, not just any neurologist, an epileptologist in a level 4 or level 3 epilepsy center near them. And there's so many of them. Almost any state, and every state has a level 4 and few level 3 epilepsy centers. So that would be my recommendation.
That's perfect. Anything you want to close with this podcast? Thank you very much. And I want to touch on the thing that you said, because I do a lot of pain management, of published things, but this is actually the first time I've really learned about the types of neuromodulation you discussed. It was definitely an educational experience for me, and I'm sure it'll also be an educational experience, not just for the general public, but even family practice doctors, general healthcare workers, because I totally agree with you. Like, knowledge in specialty fields is often not disseminated because only the specialists read their specialist publications.
Yeah. I would like to say that epilepsy surgery, including neuromodulation for epilepsy surgery, have completely changed over the past 10 or 15 years. What was available to epilepsy patients, 10 or 15 years ago was resection or vagus nerve stimulation or some of those, horrendous disconnection surgeries. The ability to diagnose epilepsy was limited to either non-invasive or invasive, what's called grid, which is a big operation to open up the skull and put a big thing on the surface of the brain. This all changed, and it changed because of simultaneous introduction of a variety of technologies that actually fed into each other unbeknownst to any of one of them. For example, when RNS was introduced, that opened up the option for what's called surgical treatment for bitemporal epilepsy at the level of the temporal lobe. As such, bitemporal epilepsy became a condition that we would like to diagnose as bitemporal epilepsy, rather than say, okay, you're not focal, just go VNS. On the same time, laser ablation was introduced, which opened up the option for treatment of people with temporal lobe and other forms of epilepsy with very little morbidity from surgery or reduction of cognitive loads. So as such, we wanted to diagnose these illnesses in which the cause of epilepsy is a deep-seated lesion that's small and tiny, such as periventricular heterotopia or hypothalamic hamartomas or deep-seated lesions. On top of all this, the robotic surgery has matured in neurosurgery that we can now use it in the human brain to implant multiple wires. So in deep brain stimulation, you have 2 electrodes. But if you want to diagnose epilepsy, you would want to implant 20 wires in the brain. And they're not implanted in areas that people have studied. They're implanted in any part of the brain, in every part of the brain. And the anatomy of every human is different. So you have to find unique trajectories and unique paths. And in order to implement this sliver path that's only 2 or 3 millimeter wide to be safe, you need the precision and accuracy of a robot. So the introduction of robotic, surgery with intracranial electrode technology would allow us to do an operation called stereo EEG, which allow us to diagnose all forms of epilepsy, which we responded to those diagnoses with therapies that include responsive neurostimulation and laser ablation, resections, and then higher form of grids and newer forms of brain mapping. And on top of all this, we've been doing what's called hybrid therapies. Like, some people, I have a patient that has a combination of laser ablation and DBS. So we did ablation and deep brain stimulation for the multifocal epilepsy without a craniotomy. And this patient is seizure-free. So these things weren't available in the past. And now this is what we do for epilepsy patients every day. And therefore, the number of epilepsy surgeries in a lot of academic medical centers and non-academic medical centers has undergone a period of growth over the past 10 years. So that's something I would like the general public to know, that we have an area in neuroscience that we have new and improved therapies and treatment options that are highly effective that weren't available before.
Actually, I have one more question. What are you most excited for when you look at the future of treatment of epilepsy? Things that you think this will be very groundbreaking.
I think because epilepsy is a fundamental functional change to the way the electrical activity of brain is done, it would benefit from the humanity civilization that includes advances in computer science, technology, electronics, power, AI. All of these feed in diagnosing treating a condition such as epilepsy, because we need to process large sets of data. We use electrical information to diagnose the epilepsy. We need a device to be able to respond quickly to a change and very rapid change in electrical activity in multiple sites of the brain. That all benefits from change in material science, computer science, electrode technology interfaces. So we are in this time in history in which things are lined up, and the human brain could benefit from that.
Excellent. The future, very bright and hopeful for patients with epilepsy. So Dr. Raslan, thank you so much for taking time out of your busy schedule, treating patients with a whole host of neurological disorders. Thank you again. Have a great night.
Thank you, Chris. Pleasure talking to you again. Okay, bye-bye.
Bye.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.